started. Okay, so it's being recorded. This is Karen Young, your ADI director. So excited to have Dr. Andrea Joy Smith in the house. And before we begin with her wonderful presentation, I also just want to do a shout out to Patsy Avery, who's going to be with us on October the 15th. She's going to be talking about mastering the future of dentistry, how digital scanning can elevate your skills, efficiency, and patient care. You don't want to miss this one. Patsy's so excited. Also, we still have a couple seats left in the implant coordinator program, which is going to be running on October 1st and again on October 14th. They're going to be going from 6 till 9 p.m. Eastern Standard Time. It's being split over 2 evenings so that it's not a full day of us being all together. And then also, if you aren't aware already, for those that are new to us, the actual one. So it runs every single month. There's some meetings that are running from 7 till 8 Eastern Standard Time, and there are some that are running during your lunch hour too. So we encourage you to join us because we talk about everything dentistry and then some. Bring your challenges. It's an open concept, so everyone is going to be able to speak and see each other. The 3 sessions that we've had so far have been actually so much fun, and we've been doing a lot of sharing about what's happening right now. So please look at joining us. Look at our website and click on all of the next 4 sessions that are going to be going on for the rest of the year. I'm telling you right now, it's an amazing add addition to your ADI membership. So if you don't have your membership already, please, it's only $50 US for the entire year. It gets you so much. You have no idea, but you can always reach out to me too, Karen at Team Dental Training. You'll have my information there.com, and I'm happy to. Without further ado, let's introduce as she goes ahead and talks about synchronizing success. Without further ado,
Thank you.
thank
Thank
you
you for
so much
having
for
me.
being with us here tonight.
I am so excited to be here. Thank you for having me, and thank you for all of you who've signed on to listen. I really appreciate your presence. Well, today we're going to talk about synchronizing success. And I'm going to talk about using my staff in my office as an example. They will be the stars of the show as they are every day in my office. But it's how that dental team drives the implant excellence during procedures, every place from the consultation all the way down to treatment. So I'll tell you just a little bit about myself. I'm in private practice for over 30 years. And right now, I operate a one-piece dental implant focused practice. I'm a diplomat in the International Congress of Oral Implantologists. I'm also an online educator and mentor through Dental Practice Mastery. And I'm very passionate about helping patients achieve their dental treatment dreams, but I'm equally as passionate about helping dentists and their teams synchronize their success. So join me as I take you on a journey through video, through demonstration, how a well synchronized team really functions. I will apologize early. I have a couple of videos that might be a little long. I'm gonna cut some of them a little short because really they're here to keep your interest, and they're also here to prove a point. They're very relevant to what I'm speaking about. So the first thing we want to talk about, I wanted to show you guys a morning at my office, and I want to show you what a well organized, synchronized success we are. I'm sorry. Well, you get the point. We are functioning in unison all day, every day. That was just a typical maybe 10 minutes out of our day, and I shortened it to a video, and I set it to the symphony of Beethoven's Fifth, just so that you could see that it is a symphony, and each of you, each staff member here represents a very important part of that symphony, as you can see with my team there. Now, the first thing, oh, sorry. All right, sorry, something happened here. Okay, I'm not sure what that is. Okay. Well, the first thing I want to talk about is the complete dental team. You all know what the complete dental team is. It is the front office, and usually the front office, they're dealing with that initial encounter with the office. They take that initial phone call. There should be great information exchange. They should schedule the appointment. They also collect the payment at the appropriate time, and then they schedule that initial consultation appointment. And at that time, they also collect the medical history information by our forms, or sometimes we do it electronically. And they also present the treatment plan, as we all know. And then we talk about the dental assistants, the registered dental assistants, the RDA, extended function dental assistants, and our registered dental hygienists. They all play a very important part in collecting the records, actively listening to the patient, addressing the patient's concerns, and providing that treatment plan. Actually, in providing treatment, they also play a very good, big role in postoperative care instructions and also maintenance. So every person in the team has a very important role. And when it's done well and it's synchronized just right, it really flows really well, like a well conducted orchestra. And then it's time for the patients to meet the doctor. Often my patients meet me before they even come into the office, and I'll show you why.
How do you and your team ease those nerves that you were talking about of your patients when they're coming in for a procedure?
The first thing is for me to meet them where they are, not to pass judgment, to sit down and speak with them eye to eye and let them know that I'm going to listen to them first, long before I look into the mouth. And my team is really good when they first bring the patient back of making them feel comfortable. So it is that personable contact that the patient that's been staying away from the dentist for a long time, that is what sets those fears at ease initially. And then once they know that we can provide their dental care under sedation, they are even more comfortable because basically they'll have the treatment done, they won't remember a thing, and they will be happy.
All right, so they meet me even before they come into the office. But that first encounter in the office is equally as important. In fact, a lot of people come in and they say, "Oh, I saw you on TV." And my next line is always, "Oh, that means we're already best friends." So that just kind of sets them at ease, lets them know I'm going to be on their side, and they can be a lot more comfortable. But this initial phone call is very important. It's a little lengthy. I might cut it off a little bit, but it actually hits all of the points in terms of the exchange of information, the setting of the patient's expectations, scheduling the appointment, and also getting their electronic patient registration to them. But this is a very good example of what that initial phone call should be like, what a really good phone call looks like. All right, here we go.
Hi, Pat. Hi, Pat. How is it going to help you schedule that consultation?
Yes, I had seen her on a show on TV a while back talking about mini dental implants.
Yes, she actually has done them for a very long time and now actually teaches other dentists to do them as well.
Oh, okay. I'm 73, so I'm sure that I have some bone loss and I don't have a lot of teeth on top. I'm sure that they'll have to be pulled out. Can the mini dental implants be used for a full arch for an upper?
Yes.
Oh, okay.
And we have different options too. So we have like an option to do a full, like a denture, to support a denture. But we also have the option to support what we call a roundhouse, which I don't know if you've ever had a bridge in the past. It's like a series of crowns fused together.
Yeah.
So a roundhouse is a series of crowns that goes from one side to the complete other. and they're cemented, so you don't have to take them in and out or anything like that.
Oh, and that's what I was looking for too. Something that doesn't snap in and out, that I don't have to worry about. That's permanent. Okay, I've never heard of this. The roundhouse.
Most of the time when we do a full arch, then they are all fused. It's one piece that's cemented on.
Okay, okay. One of the reasons I was looking into this now is that our youngest son is getting married June 1st. So I was hoping that something can be done between now and then to to be able to smile for the pictures.
Definitely.
I sure can't now.
That's okay. So our number one first step is going to be the consultation appointment. And then at that time, we will take a CT and kind of discuss what your options are. And then the second visit, if you decide that you want to go ahead and move forward with treatment, the second visit, or even on the same day if you're prepared, then it would be what we call a records visit. And that means we would take any necessary records to have a nice, beautiful set of temporary teeth made.
Oh, you mean like a mold?
Nowadays, we actually have a scanner that we put inside your mouth, and it scans all the teeth, so that way we can send that to the lab.
I have some pieces of teeth. I have one full and 3 that are just broken.
That's okay.
Would those have to be pulled first before doing this?
No, we would actually, on the third visit, we would do any necessary extractions, place the implants, and deliver teeth to you.
Wow.
Yeah.
Wow.
Now, those teeth at first are going to be temporary because we do need some healing time, and the healing time is usually 3 months. At this point, anyways, we could, if we get you scheduled for your consultation and records, we could at least get you to where you'll have some beautiful temporary teeth. Maybe even the permanent by your deadline.
Oh, that would be wonderful. I hope so. Do you know when she would be able to see me?
Yeah, we can look at the schedule right now. I do have as soon as tomorrow at 11 if you like.
Oh, you do? Oh, okay.
I do.
Okay. All right. Can I take that one then?
Of course.
She hit all of the marks. She set the patient's expectations. She told her what to expect. She set the appointment. I think it's very important when patients call in inquiring about a service that we try to get them in within the first 48 hours. That way, they don't have time to think about, oh, I really don't want to go to the dentist. Oh, that appointment's in a week from now. So to get them in within the first 48 hours is really a great idea. And on this phone call, my front office team did a really good job with that. The next encounter with the patient is that first consultation appointment. And when they come in to see the front desk, this is who they see.
I just want to make sure that Margot's song was and how often.
I want to point out something here. There's a little symphony going on right at the front desk. Sanea sitting down, she's normally the person that would greet the person at the front desk, but she is on the phone and she is talking to someone about something totally different. So I apologize if that gets in there, but it just proves how nothing really happens in a vacuum. Everything in the office functions together. And then meanwhile, Amanda has come over from her desk and she has taken over to make sure that that patient has all of their questions answered. So I wanted to just point that out while this is playing.
Breakdown of benefits. Can you share that with me? Of course. I didn't get a fax back, but they did give me her information. Your residence. Okay. Did you go my dear? You're very welcome.
I get so many compliments on how well my staff treats the patient and during all phases of treatment. And so when I started looking through some of the office video to look for examples that I could use on this presentation tonight, there was no shortage of just excellent teamwork that I saw. So then the patient gets to meet the back office team. This is my entire team, my associate, Dr. Barnes, and all of the rest of the team. They are the ones that okay, you might consider me the conductor only because our protocols are already set, but they are really the instruments that really make it all happen. In fact, I can rarely make it happen without them. So that first encounter is for the patient to have that patient interview. And as the patient is being interviewed, you'll see in this particular case, this patient looks very relaxed. My assistant is, she took her eyewear off in order to be able to look at her eye to eye. The patient is very, very comfortable. And that is one of the things that we strive for. Because as we know, patients that have stayed away from the dental office for a very long time, they are very apprehensive about even walking through the door. And oftentimes I will say, hey, you know what? I'm really proud of you for coming in today because I know how hard it must have been. And they really do appreciate that. Well, once that patient has been triaged, the next thing that we're going to do is to get a CT scan. Oh, sorry. Oh, I'm sorry. One more thing. During this patient interview, this is what we're not going to do.
You're a total catch, and any guy would be psyched to be a man. You should just make room for somebody who's nice to you. And you know what? He's honest. He told me that we are what we are, and we're just having fun. And I like that. He also told you you need dental work. He's an ass. I don't need.
Actually, that's an example. Let me go back. That's an example of what we actually are going to do. I do have an example later about what we're not going to do. So I'm going to go back. I'm sorry. I'm going to go back to now after we've interviewed the patient. That was my little funny spoof on what the patient interview is like, how we kind of meet the patient where they are. We tell them how proud we are of them to come in. We're not going to criticize the fact that they may need dental work. And so that's how we're going to receive that patient. Next, they're going to take a CT scan. I'm sorry, let's see. It should be in this click sequence. And when we're taking the CT scan, one of the things you'll notice about this particular staff member is that she's very instructive, and she really tries to make sure that this CT scan is very, very comfortable for the patient.
You're right. Swivel just your body only, but my very good, nice and straight. Okay. So here we go. I'm gonna be going up and down between this little bit till I get even better. You okay there? Okay, go. All right. Okay, so here you just don't want to move. Don't roll your chair. Stay very still. It's just gonna be a few seconds. Okay, rotation around the head. Follow the directions. Before you stand, just take a breath. And press your tongue and get your mouth just alone. Good. Count of three. Just take a deep breath. Okay, and don't move. 1, 2, 3, and freeze. And scanning now.
And what I like is that she told him every step of the way what's going to happen. These little small steps, believe it or not, make the patients feel at ease, as you'll see in some of the other videos that I have here. Then the very next thing we're going to do is charting. We have a team member that once that CT is taken, they read that CT and they give me an idea of what's going on. And then we've already saw a great example of how the patient's expectations are set. They're also set in the back office because patients need to hear it a couple of times. We actually need to reiterate it a couple of times, but I don't have to have an example of it being done here because we saw in the beginning what great expectations have been set by the front office team. And then, of course, we're going to schedule that appointment. At this point, though, we're scheduling the appointment for treatment. The other thing that we're going to do in that records besides scanning is we're going to, besides the CT scan, is we're going to set up the records appointment. And at the records appointment, we're taking radiographs, we're scanning for impressions. And after those scans are done, we take some clinical photography. And this is an example of how we're not going to handle once we see those clinical photos. I'm sorry, the sound on this one is not as good, but it does have the captions. The Big Book of British Smiles. That's enough. No, no, no. We're not going to beat them into submission. We are going to treat them with care, as you see, as my team members have already done that. And then the next thing that we do is that we order the temporaries. Actually, this has to do with clinical photos too. You will notice when we take these initial clinical photos of patients that don't like to smile, they don't really have a smile. They try to smile or move their lips in a way that they're going to begin to smile, but right before it's time to open the mouth to see the teeth, they stop it right there. And you'll see this. This is a very common first photo that I get of most of my patients. Then the next thing we're going to do is we're going to use those scans to order that set of temporaries. And then we'll also, and so once those pictures are taken, the next clinical photo is the after when she when she has a very nice set of temporary teeth in there. And this is her testimonial after the treatment. It's a little long. I'm going to cut it a little short. It actually may just be a minute and 20 minutes.
You're right. At the beginning, it was devastating because I went from doing all the public speaking, teaching martial arts, speaking at UOP at the university. I was invited to go over there and do things. And anyway, I lost all of that. In one day, I lost everything. And wasn't comfortable going out in the public, teeth out. Yes, it was horrible.
And then how many years was it from that incident of the fall to where we were able to actually give you your smile back?
Over 10 years.
Over 10 years?
Over 10 years. And I shut down. I wasn't going to family get-togethers. I wasn't talking to friends. I pretty much became a hermit. And I had seen you on TV. Yeah, I took a little still on my phone. And then when I saw you and you were talking about the mini dental implants, I thought, that's what I want. And you were so gracious about answering everything. And it's a family environment that you have here. All of your staff is really like a family, and they made me feel taken care of. And now I've got my life back, and I'm doing all the things that I used to do. I've got more friends now because I had just shut my life down. Just hiding at home.
These are the types of stories that we actually get to hear every single day. Patients have traumatic things that happen in their life, or for whatever reason, dental fear, it keeps them away from the dentist, and then they shut down. A lot of my patients were so happy when COVID came around because then they had kind of a license to wear a mask without looking out of place. So, oops, sorry about that. So now, after we've ordered the temporaries, I already had the temporary slide on there. We'll do a good baseline blood pressure, because when we're taking this records visit, we're doing our medical history update. We're taking all of our baseline records, our baseline FMX, our baseline CT, all of our initial scans. We're doing this in order to deliver the very best care that we can for the patients. Most of my patients are sedated, and when they're sedated, um, they love it because they don't really remember anything about the visit. But when they're sedated, we have to take that extra special step in making sure that they are medically cleared in order to undergo sedation. Now, we only use oral sedation medications. I don't use any IV sedation medications. And I've been doing the oral sedation really, since about 2005 is when I started doing oral sedation. And I think we do somewhere about 2 to 3 sedations a week. Didn't always start off as that many, but nowadays, now that I have a one-piece implant focused practice, when people see me on TV, they want to come and check it out. And so those are the things that we get. And then also for our sedation patients, we're going to take their blood sugar. a lot of our patients are on medications for diabetes, high blood pressure, and things of that nature. We want to get an idea. Sorry, I'm going to turn that sound off on this. We need to get an idea of how well their blood sugar is being monitored. And you'll see from this young lady here, hers isn't being monitored very well. Maybe it's being monitored, but her medications aren't working as well as they should. And so these are the things that we want them um, to look at when we want them to see their physician to try to get the blood sugar down. Or a lot of patients are on GLP-1s these days, and if they're on a GLP-1, they need to stop it 1 week before. And sometimes stopping it 1 week before will drive that blood sugar up because they've been accustomed to having it mellow and pretty consistent. And then all of a sudden we take them off for 1 week. And one of the reasons we do that is because when we have a patient that is sedated, the instructions are NPO, nothing por oris, nothing by mouth, except my diabetic patients that are on insulin, um, glipizide, metformin. Those medications actively lower the blood sugar. And so the last thing I want is for a patient to come in with nothing on their stomach, but haven't taken their medications that are going to lower the blood sugar. So those patients, we do have to eat a small meal with protein so that their blood pressure is sustained throughout the procedure. And we also keep on hand Ensure, Glucerna, Gatorade. There's things that we keep on hand to help those patients maintain the blood sugar at any given time. And then our post-op instructions, our consent form signatures, and our treatment plan presentation, they're done pretty much the same way every time. And so this is how my team does it.
Good. I have a treatment plan here for you. It looks like we were discussing to start with the top.
Yes.
And it looks like for the total cost for that's gonna be the 19.5. Dr. Smith does do a basically a flat fee for a full arch. So that's where you're gonna see this discount. And that's how we get to the 19.5.
We usually try to sit down with the patient. We don't stand over them. We show them everything that we have, and that makes for a better, a really transparent transfer of information about fees. So now let's get to the treatment procedures. We've had our records visit, we've had our treatment plan presentation, our front staff has done the payment arrangements, and now it's time for us to do the procedures. So the first thing we want to do is the procedure setup. My staff pretty much puts together everything that I'm going to need in that treatment room, and I want to make sure that those instruments and supplies, everything that we're going to need, are already set and ready to go when I enter the room. And if that's done, it can make for a very smooth visit. The last thing we want is for us to be in the middle of a procedure and then we have to stop and go and get something. That's very disruptive and also and as you all know in dentistry, minutes seconds pass like minutes pass like hours seems like days since when the assistant actually gets back to bring something. So they put the instruments in the room, they get the patient all settled in. And then from there, they're going to prepare all of these instruments. Now, my surgical setup for my implants is very simple. It looks exactly like that. And one of the things I like them to do is to prepare the anesthetic ahead of time. Oh, I'm sorry. I meant to just turn the sound down. And what you see here is this little Vibraject. It's like a vibration tool. You remember a long time ago, and maybe some dentists still do it, they shake the cheek when they do the injection. It's kind of a distraction. Well, I have this vibration tool that gets connected to the syringe, and as I'm injecting, there's vibration. And I hear so many cool responses. They're like, oh, wow, that was really cool. I didn't feel the shot. And that's the idea. Because especially when they're sedated, they're consciously sedated, so they're able to breathe on their own. We could wake them up, we can arouse them really easily. And so the last thing I want them to do is to feel the injection. However, a lot of them do feel the injection because sometimes we really can't sugarcoat it. It is what it is. A lot of them feel it, but they forget about it, which is very, very good. But on my end, I have topical sitting there for 5 or 10 minutes before I start. I use my Vibroject. I go through every possible thing that I can do to make them comfortable. I have one that connects to the syringe, and I also have one that my staff can hold extra orally while I'm giving the injection. The next thing they are responsible for is the implant armamentarium, everything from the motor, the implant handpiece, the implant drills, the implant drivers, the implant torque wrenches, and any additional information that I need, and also the implants. Most doctors use sort of a surgical kit that has like everything under the sun in it. But what I found is that there's only a few items that I use regularly, and everything else just keeps getting sterilized until it rusts and you have to replace it, even if you've never used it before. So I organize things in a different way. One of the things that has to be done with that implant motor is it has to be calibrated, and my team will do that calibration for me as well. There's a free run test that has to be done. There is a torque test that's done, and we want to make sure that the handpiece and the motor that I'm using on this particular day has enough power or is functioning at least 75 to 80% or above in order for us to accomplish this treatment without any interruption. Sorry, I'm trying to move on. All right, and then the team plays an important part during treatment. Often I'm looking in the mouth. I don't really have time to look up. So if I'm asking for an instrument to be passed to me or an implant to be opened or the motor to be pushed to the next setting, we start at setting 1 for drilling of the osteotomy. We go to setting 2 once I'm ready to place the implant. And my assistants are opening the implants, they're filling out that implant data sheet, and they're doing any charting of the anesthetic used and everything that needs to be charted while the procedure is being done.
For just a second. Four. Okay, now I see.
So I'm telling her, let's hit setting 4, let's hit setting 2, because I really don't have time to go and look at that. So that's one good thing. They're also opening the implants for me. At the bottom of the screen here, you have her opening the implants, and she's documenting, she's taking out the sticker, and she's making sure that I have everything that I need and that the proper records are being taken as well. And they're also doing the charting. They're charting the amount of anesthetic that I use. They're charting how much nitrous is used. They chart how much initial medication was administered, what they took at night, what they took an hour before. The charting is invaluable. And so they're doing that throughout the procedure. And then once I'm done with the procedure, my back office team, my dental assistants, mostly my RDAs and my RDAEF, they are fabricating those temporaries. So you'll see me in this video. I've already done my part, and now my assistant's going to step up and start trying the restoration in, and I'm really going to go on and start doing something else. Maybe I'm writing something down. They're charting that, they're fabricating that temporary, retrofitting that denture, whatever it is they need to do. Now, there are times when we need to make a temporary on the spot. And so what we'll do is we'll take that patient's teeth the way that they are now, and we make a little putty impression of it. We take A and B, we mix it together, and we put it on the patient's tooth, and we make a little bit of a mold. And so that when the time comes, I'm going to remove that patient's teeth. I'm going to place in my implants. And then at the end of that procedure, we're going to use that mold to fill with temporary material so that we can make teeth, so that the patient leaves with teeth on that same day. So that's just your typical temporary material. Some of you may use Luxatemp. There's other brands. They all pretty much work the same. You put it into a mold, you put it over the patient's teeth, you let it set, and then you come out with temporaries that look pretty much like the patient's teeth when they walked in. And we do some polishing, smoothing, adjusting of the occlusion and things like that. But those are the things that that my team will do for me before I get there to adjust the occlusion and do the other things. And then we have what's called a 24-hour care call. I want to make sure, I used to do a 24-hour visit, but our caseload has become so large that if we had everybody in 24 hours later, we wouldn't be able to get through our day. So I've changed that to a care call, a care call visit. And what I'll be showing you here is some before and afters as we go through some of the mundane tasks that we do at the care call visit. I'm sorry, I don't know why I went back. And so the next thing we do is a 1 week post-op visit. I have the patient come in because when they leave me, they're numb and they're asleep, and we can't really tell if the bite is good. Now, at that 24-hour care call, if they tell us that they're really uncomfortable, they can't chew, then we will have that patient come in so that we can adjust the bite and make them comfortable. But typically it's done at that 1 week visit. And then at the 1 month, 2 month, and 3 month visit, we're just checking. I'm tapping on the implants. I'm trying to figure out whether they're integrating well, whether the patient's occlusion is hitting too hard, causing some micro movement of the implant. Every single opportunity I get, I'm checking the integration of that implant and whether there's anything that's going to cause a problem in the future. And then once that 3 month visit is over, usually it's at the 3 month visit, we take that scan for final restorations. And then we send the case to the lab, and the case comes back and it's logged in. And this picture I threw in here because I went to a convention earlier this year, the California Dental Association. And I was just walking around the convention floor and I ran into one of my colleagues and he goes, "Hey, I saw this picture of you." He goes, "No, I just finished taking a picture with you." I said, "What do you mean? I just saw you right now." He goes, "No, there's a huge 20-foot picture of you over at the, in this aisleway." So of course, for the next 3 days, me, my colleagues, my staff, we all took pictures in front of it. It was really nice to see. And so then there's the delivery appointment. This is a little video that kind of shows you what we've been delivering for our patients over the years. As the patient walks down our hallway, we have these mix tiles. I don't know if you guys have heard of mix tiles, but what mix tiles are, you can send your photos in and they will put them in any configuration that you want. And so this is my main consultation room. And even though I didn't start out with the intention of it giving patients an idea of what they wanted their smiles to look at, they'll often point at one and say, "Hey, I want my teeth to look like those in the middle." And then my patients that have consented for me to put these here, they'll come in and they'll say something, "Wow, was that before? Was that really mine? Or did you put somebody else's in there?" And I can assure you, all of the befores and afters are true to the patients that they represent. And so they often, because a lot of times they don't really realize what condition their teeth are in. They've just been functioning, they've been hiding them, they don't look at them. Some of them may not brush them. They don't really have an opportunity to see them themselves or let anyone else see them. So now I want to take you all through a live surgery. But I want to first take you through an animation first. During this animation time, huh? Before so okay, great. I was just asking to check the time. I didn't want to go over. So I'm going to give you an animation of what I do to stabilize a denture, and then in the next video we're going to actually stabilize a denture, and then I'm going to show you what my team does to make that denture hold on to the implants. So this is an animation of really what happens. We drill just a single hole right through the gum tissue, no need to lay a flap. We then put the implant directly into the bone. And this is great because we're not disrupting the blood supply. So that makes the healing time a little bit faster. That makes the post-operative pain a little bit less because we don't open a flap. We're not doing things that are really invasive. We call it really a minimally invasive surgery. So I have about a 4 or 5 minute video of me actually doing the treatment because I want you all to get an idea of what it actually looks like when we're doing this treatment. You'll notice that I'm putting an implant after implant. So what that means is my symphony is playing behind me. I've got my assistant on one side that's actually chair side. I've got my assistant that is opening the implants. I have an assistant, sometimes it's the same one, that is actually operating the motor. but the whole symphony is taking place even though what you're seeing is me do the actual treatment. So the first thing that we do is I've already consulted the CBCT, so I know exactly where the bone is. I usually start at the midline because for the lower mandible in particular, you want to make sure that you stay away from the mental nerve. I start in the center and I go 5 millimeters from the center on either side, then 5 millimeters from there. And if I'm going to put in 6 implants, the minimum is 4 for the lower, but if I'm going to put in 6, I'll go 5 millimeters from there. And then I will measure that length and I'll go back to my CBCT and I'll figure out exactly where I am as it relates to the nerve. And that nerve also has this little anterior loop that doesn't stop at the mental foramen. It sometimes comes a little bit further. So we have my assistant suctioning, the saline bag in the motor has been changed, and that's why I get that copious water irrigation. I'm one of the team members that's operating the motor. She's looking at the amount of water, and so that when I run out of water as I'm doing my pilot hole preparation, she can change that before I even know that it's time for the water to be changed. And so, what I like about this procedure for stabilizing dentures in particular is that it's relatively simple. We take that implant directly from the packaging vial without touching it, and we insert it right into the site. And in this particular case, I put in 4 implants, and it doesn't quite go this fast. As you can see, I have the video sped up a bit, but it goes pretty quickly because I have that well organized, synchronized team. And we have all of our protocols already established, and that's pretty much what we follow all the time. So after those implants have been placed, now the patient's denture needs to be retrofitted in order for the housings to be picked up into the denture. And once the housings are picked up into the denture, the dentures themselves snap in and snap out. Now, at the very first visit, we're not picking up the housings in hard reline material, which we eventually will. We're picking it up in a soft reline material. And so I'll walk you through this video as my team member picks this denture up in hard reline material. So first we start with all of the implants in place. I apologize. I meant to play all these videos full screen, but I believe that you can, if you're watching on your computer at least, you can really get a good idea. I apologize if you can't. So once those implants are placed, I had the housings on there. Now I need to remove those housings and we need to place these small shims. Shims block out the hard reline material from locking in under the undercut of the implant, and it allows the denture to come back off once we put the hard reline material in. So we put all the shims in to protect the undercut of the implant so that the denture does not get stuck in place. I apologize again because I shot this video with my meta glasses. And what I figured out is even though I'm looking straight ahead, the meta glasses are really imaging or videoing what's sort of down below. So now we have all the shims in place. And so now we're going to put the housings back on. And so the housings will just snap right back on over the shims. The shims will be that little cover protection that doesn't allow the denture to get stuck into place. Now, I've never had to cut off a denture, but I know several colleagues who have, and it's no fun if the denture gets locked into place. And so having those shims is very, very key. And so once we do that, we then want to make sure that that patient's denture has what we call a passive fit. So what we do is we fill the tissue side of the denture with a light body PVS material. And what that does is it goes in over the denture, and if the denture is seated in its full position, we don't want to see any housings showing through that material, because what that means is that housing actually hit the denture, and that's what we don't want. We want a passive fit. And so all of the show through that we see there, it must be removed. And so we study it really well. We compare it to the denture, and then we do this one procedure again where we are checking out whether or not there's passive fit. And if there's passive fit, then we're ready to pick up the heart line, the denture. But if there's not passive fit, we go back into our lab and we take our acrylic burr and we deepen those holes and we make the spaces wider. We do whatever we need to do to that denture. Now, we always warn the patient if their denture is really thin, their denture could break through this process. And with all of our consent forms and everything that we tell them, we let them know that they may need to purchase a new denture, but we will make every effort for the denture not to fracture. And even if the denture does fracture, we might be able to send it to our lab. They can place a metal support so that they can continue that denture. But one of the things we tell them up front is when we're using your existing dentures, sometimes they're old, sometimes they're brittle. Not everybody wears them. They've been stored in a little container with no water. They can become very, very brittle. So we warn those patients that their denture could indeed break. And so this acrylic burr is just basically taking away any excess. And so we'll do one more try-in, maybe two or three, because every time we see that there is not passive fit, we have to remove all of the interferences. And then once we're sure that there's passive fit, then it's going to be time to pick. Of course, we'll do a little bit more adjusting. And then after that, it's going to be time to pick up the denture in the hard reline material. And at this point too, I try to smooth out any little rough edges, make sure it's deep enough. Just make sure that the denture is going to be comfortable and we get rid of all of those little edges there. So of course, looks like I did it a third time. This video will be over quickly, but what I want to show you is the end. When we're ready to pick up the hard reline material, we want to coat the inside of the denture with an adhesive for the hard reline material. And then importantly, we want to place Vaseline on the outside of the denture so that our hard reline material doesn't get stuck on the outside of the denture where we'll have to drill it off. We want to be able to just flake it off. So like I said, we're going to paint the inside with adhesive. Cue the video. And of course, you guys see I have a team member right there ready with everything that I need. She sees that I need more adhesive. She's going to put more in there. This is part of this synchronized team working really well together to deliver to this patient the best we possibly can. And then you'll see me put the Vaseline on the outside of the denture so that the resin material doesn't stick to it. And this particular material that I'm using has to actually be light cured. So before we can actually put the hard reline material in there, we actually have to cure it. And then we put the denture into place. We coat that outside of the denture with Vaseline. We put it into place by placing the hard reline material in there, and we are ready to seat the denture. And the next time we remove that denture, it's going to have the housings picked up inside of it. And now the patient no longer needs to worry about using adhesives or glue, or sometimes the little housings before, when I pick them up in soft line material, the little housings either stick to the implants inside the mouth or they stick to the denture. And so sometimes those housings are little small parts. So we train and educate our patients to look for them, because a lot of times that little housing will come out and they'll go, oh, one of my implants came out. And of course, I get that over the phone and I'm panicked at this point, but usually it's just a little housing. And then when we do, once the housings are picked up inside the denture, we trim that denture to make it as comfortable as possible. And then we seat that denture back into the patient's mouth. All right, so let's talk about this. I'm wrapping up now. I'm going to talk about the key points about the team. The team, as I mentioned before, is invaluable. They're organized. We keep all of our instruments rather than in a little small surgical kit, so that if I drop one item, I don't have to open up a whole new kit. I have them go in and keep everything organized into those clear boxes. And they're already following our established protocols. But one of the things that we pride ourselves on is being really playful with our patients. And I wanted to share with you guys one of our patients who's very special to us. He comes in a wheelchair. He came to me after going to like 7, 8 dentists who would not treat him. He has a lot of medical problems, and it's difficult for us to take a CT scan. It's difficult for us to take x-rays, but I really want to help people, and I will do everything that I can. So I'm going to introduce you to Mark. He's one of our patients. He was actually in this week. A few years ago, he came in like this, and I actually referred him to an oral surgeon. The oral surgeon called me back. She goes, Dr. Smith, I can't treat this patient. And I was like, why not? Well, I can't do this. I can't do that. He has this, he has that. And so I decided, you know what, I'm going to treat him. I've been practicing for, 25 years at that point, and I've seen just about everything. I've placed maybe 7,000 implants at that point, and I know what the bone behind most teeth look like. And if I would have taken out a tooth and I would have felt something funny, I would have known whether or not it was in bone or not. There's certain protocols that we're following. So I really took a chance, and I really made this patient happy. And so when I referred him, she said she wouldn't treat him. We treated him. He comes via public transportation of all things. He rides the bus and he's in a wheelchair. And in fact, his wheelchair doesn't sit upright. And then he writes me notes on his iPad because he can't speak either. And when he told me that he cried a little when he laid eyes on me, he let me know how special I was, because nobody else would really give him the time of day in terms of treatment. A lot of people, a lot of dentists, a lot of doctors, and maybe I should be a little bit more this way too. They're practicing basically not to have a problem. And, everything I do, I'm responsible for. And every patient I help, I'm liable for. And so whether it's a filling, a cleaning, something simple, something complex, I'm responsible for it. So when I take that attitude, and he became a little playful with the net as she was walking him out, I take responsibility for what I do. And when I was able to give him that smile, granted, we are doing some things on the Lord, but we can't do a lot. When I was able to give him that smile, he let me know that he was super appreciative of it. And so our team players, they know that there's no I in team. They understand our mission, and they're committed. They are committed to delivering the very best for our patients. And that's all I have. So let's see your office synchronize success. And thank you for listening. And my contact information is on that QR code. That QR code is for my link tree. And on my link tree is my contact information. All right, so Karen, we're going to open up, Karen and Tara, we're going to open up for a Q&A. I'm ready for that.
Thank you so much for being here tonight. What a great presentation.
Thank you.
If you guys have any questions, go ahead and type those into either the chat or the Q&A, whichever one is accessible for you. And I know Karen had a couple of words to say. Karen, are you there? She was having some internet issues, so I'm not sure if she's still connected with us, but.
Well, perfect. I hope you all enjoyed it. And feel free to reach out if you have any questions. I do have a question for you all. How many of you, just show of hands, by raising the hand in the Zoom app there, how many of you actually participate in delivering surgical care, surgical implant care in your offices? Great, Patsy, very good. Very good. And I do implants a little differently than most doctors. I do one-piece implants. So I just want to give everyone a flavor of how I do it in my office. And it might be done slightly different in yours, but some of the principles apply. If you're doing an overdenture, you have to somehow make that denture snap onto those implants. And so some people do it with the bar, some people do it with locators. We happen to do it with O-balls and O-rings that have a little ring in it that has to be changed every now and then. So hopefully you guys were able to glean something from this presentation that is helpful, all the way from my team members, all the way through how they help me during treatment, and how we help patients every single day.
We do have one question.
Yes.
What implant system are you mainly using for the mini implants?
I mainly use the MTech implant. MTech makes an O-ball implant. In fact, MTech was the original implant, O-ball implant for stabilizing dentures. And MTech was then sold to the 3M Corporation, and then the 3M Corporation sold those implants for a time. But at one point they stopped making them. And so they were no longer available. So at that point, I switched over to a BioHorizons implant. Now, BioHorizons implant is really basically designed almost exactly like the 3M MTech implant. all of the O-ball implants usually follow that 3M MTech design. They have an O-ball, they have a little ring inside of a housing, a little O-ring inside of the housing that snaps over the dentures. Now those O-rings have to be changed ever so often. So I'm using the BioHorizons one-piece mini dental implants. And I'm also, now they also have implants that are not mini in size. When I talk about implants, these days I rarely use the word mini anymore. I use the word one piece because we also have larger diameters. So that the mini dental implants are the ones that are 2.0 millimeters in diameter or 2.5 millimeters in diameter. But once you reach the 3.0 mark and the 3.75 and the 4.2, although the 3.75 and the 4.2 do not come in an O ball attachment, they are conventional size implants. But the 3.0 O-ball implant is called a Milo. It's classified in the conventional implant size, and we use those as well. If patients have enough bone to accommodate that, we will use it. Otherwise, for our denture wearers that have been wearing dentures for a very long time, they have very little bone. And so I have some very little implants that'll fit their bone.
Great. Another question, do you use anything other than mini implants?
Yes, I use O-ball implants that are mini in size, the 2.0 or the 2.5. I use O-ball implants that are 3.0, 3.5 in diameter. Those are conventional size implants. And then I use one-piece implants that have more of a crown preparation look to them. And those are called mono implants. And I use those for my fixed crown and bridge work. So I do use implants other than minis. And like I said, I refer to them mostly as one piece now because they are of conventional size. But I do not place conventional implants with the two parts. I do restore them. So patients will see me on TV and they'll come in and they go, well, I had this implant placed, 5 years ago and I never had the crown on top because a lot of times they don't even know that they need a crown. They've gotten a $5,000 or $6,000 bill for the implant placement at the oral surgeon, not knowing that they don't have the tooth yet. They have to come back to the office. And what I like about one piece implants is that once we reach a certain torque, we can load that implant the very same day. And the same is true for conventional implants in 2 or 3 or 4 parts. If they reach that torque, they can put a temporary tooth on the same day, but realizing that tooth has not integrated into the bone, it hasn't fused to the bone, and so they're on a soft food diet, it's low and out of occlusion, and so that we won't have any micro movement while the implant is integrating into the bone.
Okay, looks like we have one more. Someone wants to know, what is your success rate with the mini implants? They're saying my doctor says he used to use them and had failures, so he stopped.
Yeah, if you think about it, every single implant system has failure. And so there's about a 95% success rate. And I would say that is my success rate as well. Yes, I've had failures. Anybody who's placed over 8,000 implants are going to have some failures. Sometimes the failures happen early on because of the learning curve that is needed in order to really master this process. I started doing this process in 2007. And yes, I had early failures early on. So my success rate is about the same, 95% success rate. And one of the other things that I don't call attention to it unless I'm really asked, but one of the things we know about two-piece conventional implants. Now, two-piece conventional implants are amazing. They've served our community for many, many, many years. It's just that not everybody is a candidate for it. But with the two-piece implants, there's a study that says that over 50% of implants, conventional implants, develop at some point peri-implantitis. Sometimes they develop it in 5 years, sometimes in 10 years. And so that implant was successful while it was working, but if it gets peri-implantitis and has to be taken out, then it's no longer successful. So because of the micro leakage that happens with the micro movement of the parts, you've got the implant, you've got the abutment, you've got the screw that holds it all together, and you have the crown. And so every time you bite on that tooth, there's a little micro movement and percolation of bacteria. Now, I'm not saying that that doesn't happen with one-piece implants, but we don't have that movement so that the bacteria in the mouth actually get inside the implant. Now we know that conventional implantologists know that it's going to happen, but if that's the best that we could do before there was if that's the best that we can do, we do it. And then if a problem arises, we take care of the problem at that time. So one-piece implants has its challenges as well, but if we put them in, if something happens, I'm equipped to handle any particular problem that happens.
Great. Well, thank you once again for a great presentation, and thank you everybody for being here. You can visit our website. That's www.icoi.org. And on the homepage, you will see a button for ADIA. And that's where you will find all of our upcoming webinars next month with Patsy. Be sure to go and register for that on October 15th. And we also have our study club dates on there as well. So thank you again. And we look forward to seeing you all at the next event.
All right. Thank you, everybody, for joining me. I hope you enjoyed it.
Thank you.
You're welcome.
Good night.